So you will be able to see the recordings of the classes and also the presentations or the presentations that we have had so far. Okay, so it's already there
Where, sorry?
in my classes in the modules.
Okay, I see it. Thank you.
Yeah, perfect. Okay, cool. So any other question? No? Okay, then let's go to the next topic. So we're gonna talk about the pathophysiology of movement disorders, okay? And from this side, I mean, I think your syllabus is too dense. It's so many things that you have to see and then so different things that you have to check. I will try to talk with the coordinator of the course because I think it should be a bit more appropriate for you. But either way, we're gonna do what you have to do to pass your exam. And in this case, we need to check something that is it's a bit. I mean, everything is related to brain function, right? That's why we are in this course. But you need to understand different functions of the brain and of the body and the mechanisms behind it for you to actually understand what you're doing and not just memorize things. And so let's start from here. And this what I wanted to say with this is that actually you you need to or investigate but for yourself and or really uh, or try to remember. Maybe you saw this before. I think you saw all of this before, so that we don't have the time to explain all of these movement brain decisions and the pyramidal track and the extrapyramidal track. Okay, so let's go one by little by little. What is the function of the basal ganglia? I ask you to read about this. What can you tell me?
That it's important to in controlling movement.
It's important in controlling movement. What else?
Um, I think it's going to produce like the dopamine. Well, it's going to have like the sustancia nigra that is going to be the one that produces dopamine.
Okay, so basically we have that this part, this basal ganglia, is related to dopamine. Some of them we have different dopaminergic tracts, and they are used for something. And then we wanted to understand a bit more. What do you know about dopamine?
In this case, that it specifically helps like with the regulation of movement and like the disinhibition of certain pathways in order to perform controlled movements, but it's also involved in the reward system,
System, movement. Which kind of movements?
voluntary movement. Or what do you mean?
Yeah, we have movements of the body, but we have also. So basically, what you said was that we have the limbic system, right? The limbic system is the one that is related to the motivation and to the satisfaction of many of the human nature. But then we have the movement, that is the substantia nigra, and then we have another one that is the tuberoinfundibular tract. And in that one, we also control with dopamine other movements. Does anybody knows which kind of movements are those? Those are mainly peristaltics movements in the gastrointestinal tract. So all of these, for example, if you want to understand a bit better, so you need to read a bit more about this basal ganglia. We're gonna give a very, very short explanation of this because we need to advance. Does anybody wants to add anything else? No? Does anybody has a question from the basal ganglia? No? All good. I see Paola. She say no, so we'll continue. Okay, so if we're going to talk about what is pathophysiology of movement disorder, we're going to talk about two of them. Or, yes, we're going to talk about two of them. One is the Parkinsonian syndrome, that, of course, if we talk about this, we're going to focus on Parkinson's disease. And, yeah, one is Parkinson's disease, and then we're gonna check the other one is the ataxia one, I think. What can you tell me about Parkinson? A part of what you have there. Yes, Andrea.
Yes, well, I don't know if you have it there, but mainly it's like dopaminergic neuron loss because it has a degeneration of the dopaminergic neurons.
Okay.
And it affects Lewy bodies and that it mainly has like cognitive impairment, and it can lead to like slowness of movement, tremors, rigidity, and like I think that's mainly it.
Before the cognitive decline, we have movement disorder. So that's something that we're going to explain, and it's going kind of from that side. Thank you, Andrea. So let's talk about a bit of as Andrea was saying, it's a progressive neurodegenerative disorder. It's clinical manifestation. So we have Alzheimer's disease that is more cognitive related, and then we have Parkinson's disease that is related to movement disorders. And we're gonna check that is characterized by alpha-synuclein, Lewy bodies, and death of dopaminergic neurons in the substantia nigra pars compacta. So if we talk about neurodegenerative diseases, we have the king one, that is Alzheimer's disease. That is the main one. And then the second most common disorder is Parkinson's disease. It affects around 1% of the people older than 60 years and 3% in the 80 years. And it's kind of predilecting more men than women. If one of your family members have Parkinson, you have between the 5 and 15% chance to develop it in a young age due to some mutations in some related to Parkinson. And we have clinical symptoms. As Andrea was saying, we have bradykinesia, hypokinesia, resting tremor, rigidity, abnormal body posture. This is like the picture that you have here. Like this person has kind of the stoop like a bit on to the front, head and trunk, and postural instability. This happens more in the advanced stages, and this is causing a lot of falls into these patients. That it makes everything worse. A lot of patients break bones because of this, and then everything is getting worse. And then we have the non-motor symptoms like cognitive decline, and there's something that's called bradyphrenia. Who can guess what is bradyphrenia? Bradyphrenia.
Is it
Yeah.
like slowness and thinking?
Yeah, exactly. So it's kind of the same for how these people, they have slow movements. There's also a slow thinking of these patients. I mean, I don't know of these clinical symptoms, if depression, anxiety is due to the disease or by the effects or a secondary effect of the disease. Then we have, due to the treatment that we're going to see in a few minutes, we have some effects of that could cause, for example, impulse control disorders, like impulsive shopping, gambling, hypersexuality, or whatever the dopamine can generate in the brain. Okay. Sleep disturbances. Mainly at the beginning, you have anosmia, with in Parkinson's disease is one of the first parts of the brain that start getting affected, and then we have autonomic dysfunction. Like that's what I was telling you before. Due to the dopaminergic system also affects this gastrointestinal tract, you can have constipation, hypertension, urinary urgency, etc., etc. Questions so far? No, Andrea says no, so we'll continue. Okay, this is what we can show here, right? This is the stages of the disease. So put it here. Yes. So, for example, the first parts when in the prodromal Parkinson's disease. So in these patients, they already have the pathology. So you can see that there is a lot of years passing with pathology ongoing, and then there's symptoms that actually these symptoms can be for many other reasons. So it's very difficult to diagnose. And then you start having problems with the motor function, and then here is when we can actually diagnose Parkinson's disease, when you have bradykinesia, rigidity, tremor, the fluctuations and dyskinesias, postural instability, dysphagia, falls, etc. And here, until the late stage, we have dementia. So, do you know the difference between mild cognitive impairment and dementia? So, mild cognitive impairment is when not the whole, when the patients start forgetting basic stuff, right? Like, yeah, but they are not completely lost on the thoughts, like dementia. So there are many years that can pass from, even in Alzheimer's disease, from mild cognitive impairment to dementia, and this part, mild cognitive impairment, can be treated with more. It's more successful treated than dementia. So there are a couple of things that I want that we are sure that you know. One is the bradykinesia and hypokinesia, and these are slow movements. Okay, this is a hallmark in Alzheimer's disease. There are positive facial expressions, reduced frequency of blinking, speech disturbances, normal accessory movements like arm swinging during walking are absent after a while. So bradykinesia is a slowing of movement, hypokinesia is decrease of the amplitude of movement, and akinesia is the lack of movement at all. So we have that resting tremor rigidity. Resting tremor is, and this is one of the also the hallmarks of the disease, is an involuntary movement when the people is in a resting state, like you're sitting and the patients are still moving their parts without commanding that part. So it's a rhythmic shaking that occurs when a body part is relaxed and full supported against gravity. 3/4 of these patients have this resting tremor, and then one of the impressive things is that this disappears when we actually have voluntary movement. And then rigidity is just stiffness of muscles, which reduce the range of motion, but also it increases the muscle tone. So we have that first, the rigidity will increase the muscle tone, but then it will start disappearing this muscle tone when you cannot move at all. So depending how severe are these different scales for evaluate Parkinson's disease, like bradykinesia of hands, rigidity. Actually, I wanted to show you something. I just forgot. So this is the resting tremor for some of you that you haven't seen it before. So you don't need to listen to anything, but this is just a patient. Like this is a like voluntary movement, so he knows that he has to have the table holding, and this arm is not moving, but this arm is moving involuntarily, and that is the resting tremor. Okay. Sorry, 1 second. Okay, so depending on how bad are these movements and the severity of the, for example, bradykinesia, rigidity, posture, arm swing, gait, tremor, facial expression, seborrhea, speech, or independence, we're going to see how bad is this patient. So if it's from 0 to 10, it's a mild Parkinson's disease. If it's 10 to 20, when you do you add all the results, it's moderate, and between 20 and 30 it's a severe case of Parkinson's disease. But what is important for us, and what I wanted to come here, I think all of you can tell me about Parkinson's disease, right? Quick recap. What is Parkinson's disease?
I remember it being like complicated, but how I remember it is that since you lose the dopamine, there is like an imbalance in the direct and indirect route of movement regulation. I think that the direct one like enables movement. So when there's a lack of dopamine, there's like a problem in that enabling. And the indirect one inhibits movement, and the dopamine's role there is to inhibit the inhibition of that movement. So without the dopamine, that's why like they become very rigid because there is not enough stimulation of the first one, which like enables it, and the dopamine is not inhibiting the inhibition. But it's a little like a tongue twister.
Yeah, but it's very good, Pamela. Thank you. And we're gonna explain that. And I want you that at the end you go again and you explain me this. What you say is if now it's more clear after I try to explain this to you. But so far, how can you define not the pathophysiology, but how can you define Parkinson's disease? What can you tell me about Parkinson's disease of what I have said so far? Anyone?
Just like how we would define it.
Yep. Yeah,
Like a movement and cognitive impairment caused by the deficiency of dopamine or the loss of the sustancia nigra.
yeah, dopamine neurons, right?
Yes.
Yeah. So good. That's something. What else on the symptoms? Who can tell me what are the symptoms? That is not Pamela. Should I mention someone?
Tremors,
Tremors. What else?
bradykinesia,
Bradykinesia. What else?
rigidity,
Rigidity. Yes. Good. So where is it happening? Like at what age?
It can happen in 60-year-olds and also in 80-year-olds.
I mean, it's more common. Yes, it's more
Yeah.
common. There is also it can also happen in young people. That's very common. There is Parkinson's disease in the young Parkinson's disease that is like around 40 years old, and it's because of genetic factors. Okay, so that can also happen, but it's more common in patient it's a very common neurodegenerative disorder. So all of that you have said, it has to be with a part of the brain that controls movement. So we need to recap, and this is what I want you that if you don't understand this, I will actually give you, I think it's in the next slide, I'm going to give you a web page where you can actually study about movement. We don't have time to see it because it's quite complex process from the pyramidal and extrapyramidal tracks, but it would be good for you to understand this part if you have this. So we have something that is called the descending systems. There's the upper motor neurons. And to get a proper initiation of the movement, we need the basal ganglia, okay? So here is the first thing that we are gonna link. We need the basal ganglia to get proper initiation of movement. that will communicate with the motor cortex to do planning and direct voluntary movements. When we're talking about sensory motor coordination, we're talking about the cerebellum that will communicate with the brainstem centers for basic movements and postural control. Then we will have a local circuit that actually will connect to send the motor neuron pulse to the skeletal muscles, right? And so we have to go to the ganglia, and then we have to go to the spinal cord, and the spinal cord will go to the other ganglia, and then they communicate, and then we can move, and I can do this and that and that, right? So this is how it happens. So we need to have this movement that we have to have this communication between neurons in different parts of the brain to make a movement. But how possible that, like, when you are standing or now that you're sitting, which muscles are you moving?
Like just seated?
Sorry?
Just seated?
Yeah.
The abdomen,
Yeah. What else?
certain muscles in the back.
Okay.
I think a lot of muscles are involved.
And are you sending this information? Are you telling to your back all the time to be in contraction to maintain the posture?
Yes?
But in a conscious way or in an unconscious way?
Unconscious.
Yeah. So that's one of the things that happens in the movement. So we have conscious movements and unconscious movements, and that is voluntary movements and involuntary movements, and that's why it's a bit more tricky to talk about movement. Thank you, Ana Sofia. So this is, for example, two of the pathways that they are related to the dopaminergic tract for the movement. So here we have this is the substantia nigra compacta, okay? And here we have the indirect pathway, and then we have the direct pathway. And basically what we have here is that the direct pathway will actually communicate with the substantia nigra reticulata. It will communicate with the thalamus, and it will activate the cortex, and then this will go to the brainstem, and then we will have the movement. And then the indirect pathway will have inhibition in this case of the globus pallidus, which will inhibit the I forgot the name, subiculum, and then this will communicate. Oh no, this is other nuclei that can actually activate this part. So these are the tracks in the dopaminergic tract, or the two pathways that they can be followed. And the thing is that we need the direct and the indirect way. One, as Pamela was saying before, we have that in one we will activate, and we are going to be conscious of which muscles we need to activate, but also with the indirect one, we are going to deactivate other movements. So we need to have a tight balance between activation and inactivation. I have it somewhere. Yes, we have it here. Okay, so for example, we're going to talk about the pathophysiology of this part. So something that is very important here is the substantia nigra compacta that actually is the one that is communicated in the first place here, right? So it's the basal ganglia that communicates to the striatum. And thus we do it, if you can see here, by dopamine here, and then by GABA. So the substantia nigra is the one that will first activate, and we have two types of receptors, and we can talk about this a bit more in a second. So in this part, in the substantia nigra compacta, we have accumulation of misfolding of alpha-synuclein, okay? When we have aggregates of this alpha-synuclein, then we will have something that is called Lewy bodies. When we have that these alpha-synuclein and these Lewy bodies, these are called Lewy bodies, these small rounded circles of protein, that generates the death of dopaminergic neurons in the substantia nigra. The loss of dopaminergic neurons leads to the degeneration of the nigrostriatal dopaminergic pathway, and therefore dopamine deficiency in the striatum. And so here, so if these neurons die, right, then we don't have activation of this part. Are you following me so far? Fernanda? Paula, Fernanda? You look a bit lost. All good? Okay. So then we have alpha-synuclein that aggregates in something called Lewy bodies. Then we have the loss of dopaminergic neurons, then the deficiency in the striatum, and then the imbalance in the direct and indirect pathways of the basal ganglia. And there is process involved that is the oxidative stress, the mitochondrial dysfunction, and neuroinflammation. Let's go again. And this is what we need. So, for example, this is the same, and this is this part here. I'm gonna send you this today. I'm gonna add it into the in my classes, and in this website you can actually check all about movement in the basal ganglia and the indirect and the direct pathway. And this is what happens in so this is how it should work in the brain, and this is what happens in Parkinson's disease. So when we have the substantia nigra pars compacta, there are dopaminergic neurons, but they don't have a strong connection because we don't have many neurons because they are dying to the direct pathway. So we have that actually cannot activate these direct pathways. So the neurons, these GABAergic neurons, they cannot inhibit this globopallidus region. Then in the indirect pathway, we have that since we cannot inhibit these indirect pathways, so then we will have a strong inhibition in the globus pallidus, and then we will have the subthalamic nucleus that it will be hyper-excitable. And then we have an increased excitatory activity in this part, which will generate that the thalamus will be inhibited, and then we will have motor cortex less reduced excitatory activity to the motor cortex, which will generate effect in the motor function of the brain. Understood? All good? Perfect. So we can continue. We'll go again. Okay, I'm gonna show you step by step one of the things. I want you to really understand this part. So for that, we need to understand what is the substantia nigra pars compacta, and this is the site of where we have this death in the neurons. Everything based on the role of dopamine. That is what's going to lead the link between the direct and the indirect pathways in the brain. So, for example, bradykinesia and rigidity, they are due to the insufficient activity of the motor cortex. So if we don't actually activate the motor cortex, then we have this tremor and this, and this bradykinesia and rigidity in that part. So for example, this is a control of the substantia nigra. So here we have all of these neurons. This is a tyrosine hydroxylase staining. So all of these neurons are the dopaminergic neurons here. And Parkinson's disease, you can see how less are these neurons, right? We have very few neurons compared to a control group. And then here we can see these aggregates here. What do you think about these aggregates? Do they look like something that we saw just now in the other
The
topic?
Lewy bodies?
Sorry?
Lewy bodies?
Lewy bodies. I mean, these are called Lewy bodies, yes. But what we saw in the other topic, what is the difference of this with the CTE that we saw before?
Can we look to the other CT again?
Sorry?
Can we look at the other CT again?
Just, I mean, it's the same, but what are made of the aggregates in the CTE?
The same thing, right? The proteins?
Yeah, but which protein?
The tau protein.
The tau protein. Okay, so does it look like the other? Like, if you remember, we had something like this, but instead of being alpha-synuclein, we have tau aggregates of tau, neurofibrillary tangles. If you remember, NFTs, which were the hallmark of the CTE, and actually is also our hallmarks of Alzheimer's disease. Okay, that's very important, and this is happening in the same. So in our brain, something happens that for some reason we start aggregating proteins, and depending the protein that we're aggregating is the disease that we're going to get. Okay, or is Alzheimer's disease, or is Parkinson's disease. We will see that we have, for example, Huntington disease or CTE, etc. Okay, do you understand this part? Yes, no? Yes, this is Mariana Gonzalez. Okay. So we have that substantia nigra compacta, which is part of the basal ganglia. That is very well understood, I hope. Then we're gonna check why is this happening. So we have the role of alpha-synuclein, that actually we use this protein to regulate synaptic vesicles trafficking and neurotransmitter release. And it's also involved in the mitochondrial function. So these proteins, if we remember actually what happened with tau, we have that these are microtubules that they actually help to sustain the microtubules of the neurons. So these proteins, they have a function that we need them for. The problem is that for some reason they start aggregating, and then we cannot get rid of them, and then they generate these diseases. So alpha-synuclein normally is doing vesicle trafficking, helping us to release the neurotransmitters, etc. And then for some reason, they start misfolding and aggregating into insoluble fibrils. And these insoluble fibrils are called Lewy bodies. These Lewy bodies, they propagate between some neurons, like prion disease, and then for example, there's the genetic part that is these point mutations in the CNCA gene, that is the one that encodes alpha-synuclein, and that the one that generates the hereditable Parkinson's disease. So this is what we have, right? Normally, the proteostasis and the protein, how it works in your brain, is that we have monomers, then it changes the conformation, and then they start aggregating in oligomers. And then when these oligomers are aggregating more and more, then we have fibrils of alpha-synuclein, and then we have these Lewy bodies and Lewy neurites. These are the Lewy neurites, and these are the Lewy bodies that actually they are cytotoxic and they kill the neurons, etc. Here we also have a Bragg stages for these Lewy bodies, and you can see the difference. I think it was Vale that asked me before. And then we have that start from the basal ganglia, and then they start spreading to the, like for example, the Bragg stages 1 and 2, when we have is olfactory and autonomic symptoms. So if we go back to here, right here, hyposmia, for example, this is one of the symptoms, anosmia as well. And then it was depression, constipation, yeah. And then until it reaches here, until it reaches the motor cortex, I mean, like here is the prefrontal cortex, all of these parts here. Then we start having motor symptoms and sleep abnormalities. And then when in the worst part, when the brain is almost full of Lewy bodies and these alpha-synuclein aggregates, then we have the worst cognitive symptoms and affective symptoms. So how does this happen? Why do you think our brain generate these things? Why our brain? How does our brain actually get rid of these proteins? Why our brain is not, or our system is not taking care of these proteins? What do you think should happen?
Well, you mentioned previously that alpha-synuclein has a role in the mitochondrial function. So once the mitochondria starts being damaged, maybe that's making harder the process of degrading the alpha-synuclein aggregate.
Again, Estrella, please.
That the alpha-synuclein, it's important for mitochondrial function. So after the mitochondria is damaged, the process of getting rid of degrading the alpha-synuclein aggregates, it's more complicated because we don't have the normal function in the mitochondria.
That would be one. But does anybody know how we actually get rid of proteins in our system?
Oh, the lysosome is in charge of degrading,
Yes, something like
and the
this.
proteasome.
Exactly, perfect. So what happens here, and in Alzheimer's disease, in Parkinson's disease, in CTE, is why our body can or brain cannot activate this protease. It's called ubiquitin proteasome system, and this ubiquitin proteasome system, where it's like we normally what we do is we recycle proteins, right? So we have so many proteins in our brain that we needed for this or for that, and then our body's not just gonna release proteins and then it's like, okay, give me more proteins. What the body does is like, after the proteins are used, then they come into the cell, or even if they are inside of the cell, they go to the ubiquitin proteasome system, and this system what is generate like this breaks the protein into amino acids, and the amino acids are released to make new proteins, and so on. So this is the system that we are doing all the time in our brain, or in different parts of our body as well. But something happens that system actually fails, and then instead of getting rid of the proteins, then it leaves the proteins there, and then these proteins start aggregating. So this is what I was saying, right? This is called the ubiquitin protein system and the lysosomal autophagy system, both of them. By rule, by increasing age, these functions are affected. And there is, for example, age-related Parkinsonism that is actually not Parkinson's disease, just because these proteins start aggregating. So the problem is also that this alpha-synuclein inhibits this ubiquitin proteasome system, which inhibits macroautophagy and then reduce this autophagy function. So if our brain, what it does as well, remember that we cannot multiply our neurons. So the problem is that our brain or our system will try to maintain as much as possible the neurons that they are alive, but then when they are not, when they cannot handle this cell anymore, then they will do this autophagy function to actually reduce the to kill this neuron and say, okay, let's get rid of one, then nothing else happen. But the problem is that this autophagy function is also not is affected by the alpha-synuclein, and then it generates more alpha-synuclein. So this generates this vicious cycle that a bit of an aggregate will generate more aggregates and more aggregates. And this is, for example, what happened with mitochondrial dysfunction. So when we have unfolded alpha-synuclein, this is catalogized as a misfolded protein that will come to the ubiquitin proteasome system to actually release the amino acids. But since the alpha-synuclein affects the mitochondrial function, this actually will block the ubiquitin proteasome system, actually. And then these misfolding proteins will start aggregating in autophagosomes, in chaperone-mediated autophagy, and then it will generate more toxic oligomers. Instead of this actually damaging, like reducing the unfolded alpha-synuclein, will generate toxic oligomers. They will put them together. It's like if you put them in a bag, these oligomers that they actually like to be together, and then you put them all together in a bag, then they make a bigger oligomer, and then they start making these beta sheets, and then this is gonna generate a Lewy body, and these sheets also they can go to other cells, and then the neuron will die, and then they will generate chronic inflammation, neuroinflammation, and then this vicious cycle continues and continues and continues, and that's why we cannot actually get rid of these diseases as we should. There is a lot of disease research on this. I have a friend here that what they do is actually they block the autophagy of the neurons, and when you don't have autophagy, so what it should be worse for the cell, but what it happens is that actually the pathology is less aggressive because you don't help to put together these proteins and to make them like to glue together and generate these toxic oligomers and beta platelet sheets for the Lewy bodies. So this is actually roughly what it happens in AD. In Parkinson's disease, in PD, and this is actually the mechanism. Now, is it clear now? Do you understand a bit better this part? Okay, Pamela. Can you try to explain again this if you... She's not there, maybe. We lost her. Someone else. Who can explain what happens in Parkinson's disease?
So basically, a part of the brain called sustancia nigra is affecting different pathways of the dopamine. That could be the direct and the indirect pathway, and that would lead to consequences in other parts of the nervous system that would eventually lead to all these consequences, cognitive and movement consequences.
Normally, the substantia nigra, their normal function is to activate with the dopamine, the indirect and the direct pathway. So that's normal. But let's take, for example, Ana Sofia, let's take one step. Like I did from the region to the molecule. I would like you to try to do from the molecule to the region. What is happening? Like we have a healthy cell. Then what's happening in Parkinson's disease?
O sea, como de otra manera, cómo funciona, how it works, like in normal,
No,
without the pathology.
no, in a pathology. Like, what is the main driver of Parkinson's disease?
The degeneration of those dopaminergic neurons.
Perfect. The degeneration of dopamine neurons. Why? Who else can tell me why? why these dopaminergic neurons are dying?
The aggregation of alpha-synuclein due to this proteasome system and lysosomal autophagy that it's failing with age.
Yeah, I mean, in age or in Parkinson's disease, right? Also, I mean, could be genetic, but okay, Estrella. So, aggregation of alpha-synuclein. What is the name of the aggregates of alpha-synuclein?
Lewy bodies.
Lewy bodies. So we have aggregation in our cells, in our dopaminergic cells, in the substantia nigra compacta. We have aggregation of alpha-synuclein and forming these Lewy bodies that generates the death or that causes the death of the dopaminergic neurons. Yes? So
Yeah.
if we have that, then we have that we don't have this communication to the direct pathway and the indirect pathway. So if we don't have this communication, so we cannot actually generate this circuit that will generate the motor activity. Do we understand this part? Yes? Yes, no? Yes? Paola Fernanda say yes? Okay. Okay. So this is for me what I want you to understand and what this is the important part. So for the treatments, so we have this. If we understand the effect of Parkinson's disease or what is happening, what should we do to treat this disease? What would you do?
Substitute chemically what's the substantia nigra creating.
Okay. So how would you do that? What would you give?
With analogs of dopamine.
Analogs of dopamine. Yeah. What else? What else would you do, guys?
Maybe try to inhibit the enzymes that degrade the dopamine produced.
That's something important as a coadjuvant of the treatments. Okay. So actually, yes, we have here. This is the normal pathway. We have tyrosine, L-dopa, dopamine, noradrenaline, adrenaline. This is actually how we synthesize dopamine in our brain. And for example, the gold standard for symptomatic relief is levodopa. So you give to the patients this, they will have more of the precursor of dopamine. So then we will be, even though we have less neurons, dopaminergic neurons, we're gonna push the dopaminergic release. Okay, that's why levodopa is the first one. Then we have dopamine agonists like MAO inhibitors or COMT inhibitors, and other kinds like ropinirole or this one, pramipexole. And then we have something that is called amantadina, that is an NMDA receptor antagonist, but this is in the very early course of the disease, which is supposed to enhance dopamine release from the nerve terminals. So in this case, this is just to try to push that dopaminergic release. And this is what we have, okay? Normally, we have the inner blood, we have levodopa running around. we need dopamine in our system as well. So we have with this enzyme, the ADC, we're gonna form in the blood dopamine, and with the COMT, we're gonna form 3-OM dopamine. So we can do different things. If we use these drugs, we can avoid that this enzyme is working, so we will have more L-DOPA levodopa in our system. If we use these drugs as well, we're going to have more levodopa to bring it to the brain. And once we are in the brain, we're going to bring it into the neurons, and in the neurons, by the aromatic L-amino acid carboxylase. So we're just going to get rid of this carboxyl. We're going to form dopamine, and then dopamine will be released. Once dopamine is released, we have different options. One is to bring it inside again into the vesicles and then have it ready to release again, or we can actually degrade it with this enzyme, the MAO, and this will generate DOPAC, or another, again, the COMT, the same that we have here, and we can actually, we're going to produce other metabolite of dopamine, of the dopamine. So what we can do is actually block these enzymes and then prevent and to have more dopamine in the synaptic cleft to activate the receptors and to bring it into the recycling again. And then we have some dopamine agonist. So we have the dopamine agonist that will bind to the receptors 1 and 2. And that is like doing the effect of dopamine, right? So we have this apomorphine. I have a paper actually that I was working with amphetamines before, and that we were working apomorphine at some point. So what you do is just actually trying to activate these dopaminergic receptors. Questions here? Yes, Paula. Fernando.
Yeah, well, since dopaminergic neurons are not that are dying, what will happen also with adrenaline and noradrenaline? It is like an option to give to the patients like microdoses of agonists of adrenaline, or
No, because for example, one of the things, I mean, I'm going back here. So that's a nice train of thought. But the problem here is that we have only 3 regions in the brain that generate dopamine, but we have other regions that they actually generate noradrenaline. So it's not the same. So this region in the brain, these neurons here, they have dopamine receptors. Even though if you put noradrenergic substances, they are not going to affect here. They will affect other parts of the brain. Okay?
okay, super, thank you.
Yeah, thank you. Okay, something else? Questions? No? Okay. So levodopa is so the thing is here we're trying to recover a bit of the transmission. Are these treatments actually preventing the death of the dopaminergic neurons?
Not really.
Not really. So this is just symptomatic, and this is just it will last for a time, some years, but then this is a progressive part. So this is just to try to the patients to control the movements for a while. We have seen also that like the patients are getting resistant to levodopa, so then you cannot give it for forever, so that you will need concentrations higher and higher and higher concentrations of these to work. So it's recommended just when you really need to use like this, when you really need to control your movements, just to don't exhaust your system of the levodopa use. So motor complications affect 30% of the patients after 2 to 3 years. So there's the secondary effects, and then more than 50% of the 5 years of levodopa use show also motor complications due to the use of the levodopa. So you have also fluctuations. There's called on-off oscillations. Symptoms are controlled when levodopa is effective, and the symptoms return when the drug is washed off. They are caused by short levodopa half-time, absorption variability, pharmacodynamic changes in the striatum, and then this generates these dyskinesias that are involuntary movements. So there has been a lot of research on that, how to do. They have shown that actually, if you take I don't know if it was levodopa with milk or with orange juice, they absorb better, and then the effect is actually easier. There is a lot of research ongoing with this one. And then we have a surgical treatment. So if we go back here, what we can do actually is activate artificially these pathways. Okay, if we put an electrode and then we activate these nuclei, then we could do it, and we could actually manage them. And what we do is basically this: with the deep brain stimulation, what we do is to insert into the brain an electrode to the subthalamic nucleus or the globus pallidus. Okay, so the globus pallidus or the subthalamic nucleus, to actually activate these regions of the brain. And it has been shown to work with high frequencies between 100 and 200 hertz. So this generates like the effect of a lesion, and you don't need to actually destroy the brain tissue. So you just go inside there, and then you have these frequencies that stimulate this region. So in the DBS, what we have is that we place an electrode, or that we actually try to, with this frequency, stimulus frequency, we go to the globus pallidus, and then, for example, we have that we don't have enough inhibition to the subthalamic nucleus, but when we activate it externally, then we have this activation. So instead of having this will actually reduce the excitation of the subthalamic nuclei, and then we'll communicate with the globus pallidus in a reduced excitatory activity, and then all of this will be fixed as we have it in the beginning here. Okay, so then this will be restored if we only target this or this nuclei. Okay, so yeah, so then when we target these structures, we have reduction of hypokinesia, reduction of dyskinesia during on phases, and reduction of tremor if we target different structures. And then, yeah, this is Parkinson's disease. Questions so far?
I have a question.
Yep.
I've read more papers of DBS on the subthalamic nucleus than in the globus pallidus. But if they're both in the indirect pathway, what's the difference? Why do they target more the subthalamic nuclei?
I think they have better results when they actually go to the subthalamic nuclei. So you actually don't need to. I think it's more difficult to access to the globus pallidus externus. So what you target the subthalamic nuclei, and what you need to do is just to reduce the excitation here. So I also found the same. I was trying to find a picture that you could show, like I could show you where it was in each of the ways of the global pallidus and the subthalamic nuclei, but normally they target more the subthalamic nuclei. I don't know if yes this like if they target this structure, then we have a reduction of the hypokinesia, less frequent and less intense of phases. And then here you have less effect, I would say, like reduction of dyskinesia during on phases. And then if you go to the venturi intermedius of the thalamus, you have reduction of tremor. So basically, I think is which gives you a better effect on what you are looking for. And then
Okay, thank you.
for example, you have less reduce of the pharmacogenic treatment. So it's a win-win in that case. But all of these again, it's not fixing the disease. This is just for the symptoms. Okay. Okay. Cool. Questions? Another question? Okay, I'm gonna make a deliverable for I'm gonna put it for Friday. I think it's I'm gonna put it for Wednesday. I'm gonna put it for Wednesday, and actually I want you to explain me the difference between chorea, atheotosis, and balismus. Okay. I'm gonna put a rubric there. I will do it later today, and then you will have it for Wednesday, so we can discuss it on Thursday morning for you guys. So we can take this this second part more like faster. Cool. Questions?
Is it going to be a diagram or like a written
I
essay?
don't know. I don't know. I will think because I want you to also compare them. Maybe a table. Yeah,
Okay.
maybe a table. Yes, but I will put it. I just need to pick up my daughter now, and then after that I add it. Okay. So please later today, like noon or something, check your the canvas and it will be posted out. Maybe I will send also an announcement, something. Cool. Okay, perfect. Thank you guys. Have a nice day, and see you on Thursday.
Have a nice day, doctor.
Thank you. Nice day.
Thank you. Bye.
Thank you. Have a nice day.
Bye.
Doctor,
Yeah.
I entered late because I couldn't find my charger, so I didn't take the roll call.
Okay. Okay. I fix it.
Thank you. Have a nice day.
You too. Bye.